Good afternoon, everyone. I feel it's my honor and privilege to stand before you and welcome all of you once again to this conference. We feel proud and honored to have with us Honorable Minister of Revenue and Land Reforms of Bihar, Dr. Dilip Kumar Jaiswal, sir, who is also the director of this pious medical institution. I would request respected sir to take his respective seat on the stage. Sir, please. I would request Professor Dr. Bijan Chandra Datta sir, Principal Mata Gujri University, to take the respective seat in the stage. I would request Professor Dr. Ashitavo Devroy sir, HOD Department of Pathology and Vice Principal Mata Gujri University, to take his respective seat on the stage. They are our supporting pillars and true inspiration to all of us. May I now request Dr. Atunu Ray sir to come on stage and felicitate our Honorable Director and Minister of Revenue Land Reforms of Bihar, Dr. Dilip Kumar Jaiswal sir. सामने सामने अरे मेरा May I now request Dr. Nivedita Haldar ma'am to come on stage and to felicitate our Vice Chancellor sir, Professor Dr. Sudipto Bose. May I now request Dr. Tapan Mukhopadhyay sir to come on stage and to felicitate our principal, Professor Bijan Chandra Datta sir. Now I would like to request Dr. Ashok Prasad sir to come on the stage and to felicitate our Vice Principal sir, Professor Dr. Ashitavo Devroy.
May I now request all the dignitaries on the stage to light the lamp and formally inaugurate the conference.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्या.
I am delighted to announce that the conference souvenir will be inaugurated by all the dignitaries present on the dais. So I request all of them to kindly inaugurate the conference souvenir. May I now request Professor Dr. Asitavo Dev Roy sir, Vice Principal MGM Medical College and Head of Department, Department of Pathology, MGM, to deliver his valuable insights.
Good afternoon, everyone. Honorable Director, sir, Honorable Vice Chancellor, sir, respected Principal, sir, all the respected eminent speakers who have come from all the corners of India, all respected delegates who have registered for this conference. I welcome you all to this two-day national conference, Investicon 2024. Organizing conferences is a passion for me. It's kind of a hobby. But then, if you do not have an active team, if you do not have administrative support, you don't end up having a successful conference. And I'm very lucky to have a very, very dynamic and active team over here at MGM Medical College. And above all, a very, very supportive administration and management, without whom this conference wouldn't have been possible. It is indeed a pleasure and a moment of pride that we have all gathered here, and the Bihar Medical Council has granted 8 hours, credit hours to us for this conference. And as a pathologist, today we were discussing about precision medicine, we were discussing about digital pathology, we were discussing about artificial intelligence in pathology. I remember my days of PG, when I had read an article by Professor Nirmala Jambekar madam from Tata Memorial, Mumbai. She wrote an article which was titled, On Becoming a Thuk Pisap Doctor. And she had mentioned in her times how it was difficult to choose a subject of pathology as a postgraduate subject, as a subject in PG. When I chose pathology over surgery to do my PG, during my counseling, the teachers over there told me, "Larka ho ke pathology karega?" So I said, sir, if I become a surgeon, I would become a very bad surgeon. So let me choose my subject myself. And today, I think whatever I am doing it from my heart, and I am doing it well. And today, from all pathologists, what we are doing, we have come up from that becoming Thuk Pisab doctor, and today we were discussing very vividly about precision medicine, about artificial intelligence in medicine, about immunohistochemistry, and it gives me immense pleasure that we are doing that here in this institute of ours. And I would like to tell you all that very soon, with the discussions are already on with the management. Yesterday I was also discussing with Uma Nahar madam from PGI Chandigarh that we will be very soon having a digital pathology set up in our institute. So with this, I thank you all once again for coming here. Thank you.
Thank you, sir. Thank you for your kind words. May I now request Professor Dr. Bijon Chandra Datta, sir, Principal, MGM Medical College, for his valuable inputs.
A very good afternoon to all of you present here. Honorable Director, sir, Honorable Vice Chancellor, sir, respected guests, dignitaries on the dais, the students and the office staff present here. It is a great privilege for me to be here this afternoon. First of all, I would like to welcome today's guest speaker and invitee from different institutes of our country to today's event, Investicon 2024, organized by Mata Gujri University in collaboration with the departments of pathology, microbiology, biochemistry and radiology of MGM Medical College. Now the concept of today's event, Investicon 2024, has significance because this is a common platform where all 4 departments related to various investigations are gathered here. And they are involving here also. The Investicon 2024 is mostly focusing on integration of investigation part according to the present situation of the healthcare system scenario. As all of you know, the diagnosis of a patient depends on various investigations, whatever it may be. It may be a blood sample, it may be the tissue culture, it may be tissue histopathological studies, or it may be radiological study. So getting the right diagnosis is a key factor for a clinician or a physician, which provides a right explanation of a patient's health problem and informs the subsequent health care decision. Anyway, so keeping all this in mind, today's theme, the unraveling the diagnostic tapestry in the field of patient care. And I believe the importance of unraveling the diagnostic industry in the field of healthcare system would definitely be beneficial to the patients, as well as it will encourage the young students who get the encouragement as well as motivated for a new innovative technique or develop new ideas in the field of patient care system. I also believe the importance of building up a strong relationship between clinician and investigation related to diagnostic department, that is pathology, microbiology, biochemistry and radiology, so that we can achieve our goal. I am confident that today's event will be a fruitful one. Thank you all. Namaskar. Jai Hind.
Thank you, sir, for your kind and encouraging words. May I now welcome Professor Dr. Sudipto Bose, sir, Vice Chancellor, Mata Gujri University, to give his insights on today's conference.
Good afternoon to one and all. Honorable Director, and now we have what we can say a two-in-one. Also the Honorable Minister of Revenue and Land Reforms, Government of Bihar. Respected Registrar Mata Gujri University in absentia, respected Principal, Vice Principal, all faculty members, invited guests who have come from all across the country, including leading institutions. Madam, you have taken all the trouble of coming from Chennai. And in this weather, however, we traveled it easy. My friends from the print and visual media, all categories of staff, dear students, resource person, ladies and gentlemen, it is indeed a great pleasure and an honor for me to welcome you all in today's two-day workshop. I'm sincerely very happy, and it's a sense of contentment that this university within this fledgling time has made leaps and bounds progress. And that, may I say, is because of the participation, involvement, and the sincerity of all and one of the individuals. Of course, undoubtedly supported by the management and everybody. Now, as the theme goes here, we as clinicians, I've been a gynecologist, obstetrician, having retired in 2014 from one of the government medical colleges after a long 32 years of service. Those of us who have taken to clinical, it is not only the clinical aspect, but the supporting system, and the supporting system has over the years, previously it was chemistry, there was no biochemistry in our times, let me tell you. Biochemistry, pathology, now microbiology, pathology in our times, those who are of the senior years would corroborate with what I'm saying. Pathology was, microbiology was included in it, now it has gone to separate subjects. Radiology has made leaps and bounds. And therefore, a wise clinician would be dependent on that. And please understand one thing, the clinicians I see very few, one and in between. The patient is the most important person for which we are working. And for that, one must be humble enough to accept the changes and to institute those changes, work in harmony for the benefit of the patient. And that involves a clinical. And there was a time, let me tell you, and I'm not speaking through my head when I say, that clinicians, as the vice principal said, pre-para, they were neglected. And that is why one good thing the NMC said, they are all doctors. No pre-para clinical. And everyone is as far as they fit in like a slot. Everyone has an important role to play. And this is what I want to instill. And I'm very happy that such a program is being in, and this is the second time, and because it is a two-day program, so therefore I believe 8 credit hours have been granted. Moreover, as you understand, faculty members from the leading institutes have come. I'm from West Bengal, so I see also from AIMS Kalyani, and then of course PGIMS Patna. We are grateful that you have taken all the trouble of coming and joining. I wish this workshop a great success. Thank you from the core of my heart. Thank you.
Thank you, sir, for your bold and kind words. Finally, may I now welcome Dr. Dilip Jaiswal, sir, Minister of Revenue and Land Reform, and who happens to be the director of this institute, to kindly share his views on today's topic.
Good afternoon to all. Vice Chancellor Professor Sudipto Bose Sahab, Principal Professor Bijan Chand Datta ji, and our Vice Principal Professor Asdav Dev Rai Sahab, and all the delegates. I take this privilege to welcome all the delegates who have registered for this two-day national conference, Investicon 2024. It is a matter of great honor and pleasure and pride also for the institution that we have speakers, such a great person, Professor Biman Saikia, Professor Uma Nahar Saikia from PGI Chandigarh, Dr. Indranil Chakravarti from AIMS Kalyani, Professor Anup Bowler from Bardhaman Medical College, and Dr. Randhir Kumar from IGIMS Patna. Who is Mr. Randhir Kumar? Oh, you are, okay. We also have amongst us our very own senior oncopathologist, Dr. Ashitab Mandal, who has always seen a part of all our academic activities so far. I thank you for taking this pain to come all the way to our institution, such a remote area in Kishanganj. The aim of this multidisciplinary conference is to provide a forum for the exchange of scientific and technological innovations resulting from research in the relevant fields. The insightful and stimulating conversations between the attending, all the participants in this campus, and will result in a significant discussion of ideas throughout this conference. The advantages of this kind of information sharing will be very beneficial to patient as well as the medical community, as said by our Vice Chancellor Dr. Sudipto Bose Sahab. It was a source of great joy to learn that the departments of radiology, pathology, microbiology and biochemistry, Mata Gujri Memorial Medical College, Kishanganj, are organizing the Mata Gujri University Investicon 2024 on today 22nd and 23rd June 24. Therefore, I would like to congratulate the organizing team for taking this great initiative to hold this event in this campus. And also, I hope this will now become an annual academic event of the institution, and our administrations will always support and encourage such activities in future also. I once again extend a warm greeting to all the attendees and participants of the conference and wish to organizing team the best of luck for your participation in this campus. Thank you. Thank you.
Thank you, sir, for your encouragement, guidance, and unwavering support. May I now request all the dignitaries on the dais to kindly take their seat with the audience.
My topic is workshop on true cut biopsy, procedure and interpretation. So you actually that procedure part I will cover as a video clip and hands on. Now let me start with the interpretation part from the pathologist point of view. So for years, CNB has, that is core needle biopsy, has been used extensively for initial evaluation of breast lesion. It has also become the first line procedure in diagnostic workup in many tumors and non-neoplastic lesions, as already discussed by Dr. Pathak, in kidney tumors, kidney parenchymal disease, and also it has got particular importance in case of lung cancers and soft tissue tumors. For breast, what we see, it allows rapid diagnosis of palpable and non-palpable, where ultrasound guidance or image guidance is required, breast lesions. It is highly specific and sensitive, particularly with image guidance for diagnosis and initial classification. It has got excellent correlation between the findings of core needle biopsy and those on open excisional biopsy, which indicates its high diagnostic utility. Preliminary histological grade is made when invasive malignancy is found. So, what we give when we handle a core needle biopsy slide of a breast carcinoma or suspected breast carcinoma, initially what we do, we offer a histologic diagnosis that this is invasive duct carcinoma or invasive lobular carcinoma, whether interductal component is there or not, whether we are getting LVI, that is lymphovascular invasion, is there or not. So, these are the initial way how we approach to the diagnosis of breast carcinoma cases from true cut biopsy sample. Then we try to grade it, and usually we follow the recommended grading systems, that is modified SBR scoring, which is based on this scoring system. But there are definitely some problems which I will discuss subsequently. And then, so limited, this has got other advantages like limited cold ischemic time and excellent fixation makes it suitable for ISC. So, Dr. Indranil told about the cold ischemic time. I think you have got some idea. So, it is easily manageable because of small core of tissue and your fixative is always almost beside your hand. So, whenever you are doing the procedure, you can place the tissue sample into the formalin fixative, that is buffered formalin fixative, which is the optimum fixative for this core, handling these core biopsy samples, which is already available with you, and as early as possible you are getting the core, you can place it into the formalin, so that you can overcome the challenge of inadequate fixation. So, and another important thing is that excellent fixation makes it suitable for ISC. For cold ischemic time, for this core needle biopsy, it is usually preferably it should be less than 30 minutes, but you can extend it up to 1 hour is acceptable. And fixation time is usually 24 to 48 hours, and it should not cross 48 hours, as Dr. Indranil has also told that it should not be more than 48 hours. The disadvantage, you know, it has already been discussed that there will be chances of cross-linking formalin with the nuclear material. So, there will be inadequate expression of the DNA, nuclear details, etc. That means molecular characterization. Now, so dependence on core needle biopsy for histologic diagnosis along with preliminary grading and IHC, that is immunohistochemistry for ER/PR, HER2 and also Ki67, makes core needle biopsy preferred sample type for treatment decision and possible neoadjuvant therapy before surgery. You know, after getting the histology diagnosis and grading, we submit the case for sample, that is formalin fixed paraffin embedded cell block. That is the standard recommendation that it should be formalin fixed paraffin embedded, and this section is submitted for IHC, particularly for ER/PR, HER2 and Ki67, and then subsequently therapeutic strategy is made according to the basis. Now, in case of lung, what happens that core needle biopsy is one important and useful approach to procedure of small diagnostic sample. Before this, you must be having some idea about the small diagnostic sample in case of lung tumors. You know that small diagnostic samples can not only include the biopsy material, but also it includes the cytology material, particularly in the form of cell block. You can prepare the cell block and that submitted for the histological evaluation and subsequent workup. So, it also includes. And if we go for the biopsy, this can be bronchoscopic guided biopsy or this can be core needle biopsy. So, there are different types of biopsies which are usually useful for lung carcinoma cases workup. And today obviously our focus is on core needle biopsy, and you know that core needle biopsy usually we focus or concentrate on the masses which are peripherally located and easily accessible. And in case of lung, CT guided biopsy procurement is the best choice, as Dr. Pathak has already told about this, how the material is collected and how it is managed. Now let us discuss some terminology used for different lung cancers in the diagnosis. So these are particularly recommended as per WHO guideline, which we use this terminology in connection with the small diagnostic samples. So what we do, if it is a carcinoma, we usually offer a diagnosis of squamous cell carcinoma if histologically it is clear cut showing evidence of keratinization. And also adenocarcinoma if histologically we get clear cut evidence of gland formation. There WHO recommends no additional ISC confirmation is required because your material is less and you should not be confined with only offering a histologic diagnosis like adenocarcinoma or squamous cell carcinoma. You will have to do lot of things because of this precision medicine, which is nowadays has come up as the most acceptable way approach to the treatment. So you will have to have the material. WHO has recommended only minimum ISC, particularly if you are suspecting that this could be squamous cell carcinoma, which usually occurs or happens in case of non-keratinizing squamous cell carcinoma or basaloid squamous cell carcinoma. There you can apply ISC, and initial ISC panel should include only 2 markers. For adeno, either it is TTF1 or napsin, and for squamous it is P40, you know that is the most specific marker. And ISC for neuroendocrine markers are particularly useful only when your finding morphologically supports the possibility of neuroendocrine. Otherwise, that small material should not be misutilized with the additional section which might cause the loss of your tissue, which is very much valuable for your molecular testing and subsequent management. Now coming to that terminology, that small cell carcinoma favoring adenocarcinoma. If you go through your WHO book, you can see this, that non-small cell carcinoma favoring adeno. When you will call this non-small cell carcinoma favoring adeno? When your core is not showing features of, neither showing features of adeno nor showing the features of squamous, and after application of these 2 ISC, you are getting in support of adeno, that is TTF1 or napsin positivity, then you can issue your report as non-small cell carcinoma favoring adeno. That does not mean that that case is adenocarcinoma, because this adenocarcinoma or squamous cell carcinoma is a diagnosis of resected sample. So your core may include that material which is showing adenomarker positivity. That's why your reporting terminology will be small cell carcinoma favoring adenocarcinoma or small cell carcinoma favoring squamous cell carcinoma, like that. And in this connection, another question is there. Suppose the cells are showing both P40 and TTF1 positivity. Then what will be your bottom line impression? Anybody? PGTs? Suppose the cells are showing both P40 and TTF1 positivity. Can you think this is adenosquamous? Can you release your report as adenosquamous? No. Because these cells are definitely, when showing TTF1 positivity, are adeno. These cells are adenocarcinoma, but showing aberrant expression of P40. That is very important take home message, that in small biopsy, same tumor cell showing both TTF1 positivity and P40 positivity is definitely adenocarcinoma showing aberrant expression of P40. Although we are much more stressing that P40 is a very specific marker for squamous cell carcinoma in lung, still there can be chances of aberrant expression of P40. In that case, we will definitely give our report or release our histomorphologic report, that is a case of adenocarcinoma with P40 aberrant expression. Now, in your core, if you are getting that some cells are showing P40 positivity, some cells are showing TTF1 positivity, then what will be your bottom line diagnosis, or how you will release your report? From core, some cells are showing positivity for TTF1, some cells are showing positivity for P40. So what will be your diagnosis? Yes, adenosquamous, but are you very much sure that this can be adenosquamous? Because it is a diagnosis from the small biopsy. At adenosquamous carcinoma, to stamp it as a case of adenosquamous, minimum of 10% of the tumor cells should be having any marker positivity, or actually that is also morphologically that should show the areas of squamous differentiation and adenodifferentiation. So unless and until you are having a resected sample, you cannot diagnose it as adenosquamous carcinoma. Rather, you should diagnose it as a non-small cell carcinoma or non-small cell carcinoma with expression of both adeno and squamous markers. So that should be your bottom line. So these are important tricky points whenever you are reporting your histology from core needle biopsy, you will keep all these things into your consideration. Similarly, for non-small cell carcinoma, NOS. So when all the markers are negative, then you can release it as a case of non-small cell carcinoma. So after getting that histologic diagnosis done, the workup is to submit this case for this material or paraffin embedded block for ISC based tests, which may detect where napsin, TTF1 or P40 etc. may be utilized when you are unable to diagnose it as squamous or adeno from histomorphology alone. But don't waste the material if you are very much clear on histomorphology examination. So you shouldn't go for this TTF1 or P40 ISC. Rather, you can go for ALK or ROS ISC based tests. You know, ALK ISC is almost equally effective or in screening, which is having equal value as fish ALK, but ROS is not that ROS IC is not that much dependable. If you are getting, it should be confirmed by ROS fish. Then PCR based tests should be done for EGFR, BRAF, KRAS, etc. and fish done for ALK and ROS1 translocation and MET amplification is done. So these are that's how you utilize your material for ancillary investigations. Now the question comes, when what should be the initial, as I have told that initial ISC panel will be of 2 if you have any doubt about the histomorphology. But what should be the ideal molecular panel? Initially it was thought that it should cover EGFR, ALK, ROS, but it can only be done when your material is very less. Otherwise, you should have EGFR, BRAF, ALK, ROS as an initial workup, and that is the NCCN guideline. Along with this, you will have to have IAC, and that IAC is not for this lineage specific marker, rather that IAC is for PDL1, which Dr. Indranilu has also told, that PDL1, and in case of lung, you will have to have your observation, that is tumor proportion score, TPS, tumor proportion score. So you will have to look for PDL1 positivity in the tumor cells. Instead, in breast, you will have to look for CPS, that is that combined score, where you will see for PDL1 positivity in the tumor cells and associated immune cells, which is divided by the all tumor cells into 100, that is the score. And you see if the value is more than 1, that is supposed to be, those cases are respondent of this immune checkpoint inhibitor or PD-L1 inhibitor therapy, and if it is, the score is more than 50, it is supposed to be excellent. Another thing which I should say, that is the tumor mutation burden, that I am discussing later on. Now for soft tissue tumor, what we see, that is also an usual approach where multiple cores are obtained, and after initial histologic evaluation is done, after getting that slide, what we do, we go for initial histologic evaluation, like it is neoplastic or non-neoplastic. So that idea also where the clinical and radiological support is there. So from there we'll give an idea, we'll get an idea about the neoplastic nature of the lesion, and if we are very much sure that we are dealing with the case of neoplasm, then we'll concentrate on whether this is benign or malignant, right? And if it is malignant, obviously the workup comes, and initial approach is definitely pattern based approach. Like some soft tissue tumors are showing fascicular pattern, some tumor cells are showing nested pattern. So this pattern based approach should be required for initial histological evaluation of that malignancy. If you are getting malignant, or if you are suspecting really it is malignant, then you go for that grading system. You know, FNLCC grading system is there, but still there are some limitations because of necrosis and mitosis. Sometimes there might be all the areas are showing necrosis, sometimes there might be chance that you are missing the mitosis. So these problems are there in initial grading of a tumor or soft tissue tumor from this limited biopsy material. And accuracy in histological subtyping and grading is so this accuracy is directly proportional to the amount of representative material. Obviously, true cut biopsy or core needle biopsy, being a small material, there are chances of underdiagnosing or undergrading the tumor. That should be kept in mind. Then comes that IC based test done for lineage specific markers and with the use of next generation antibodies where it is required. And tissue may be used for FISH, you know, that is detection of translocation associated sarcomas. I think you might be having some idea about the translocation associated sarcomas. You know that many of the sarcomas are translocation associated, where chimeric proteins are getting the marker, becoming the marker. Monoclonal antibodies are developed against that chimeric proteins, and that's one example of next gen antibodies also. You know, initially we targeted IHC based tests to detect the intermediate filaments, that is like cytokeratin, vimentin, desmin, all you know, you are quite familiar with this, but subsequently it comes and there is evolution of idea that not always all tumors are showing this typical lineage specific marker positivity. Emergence of the ideas that regulator of chromatin structure, epigenetic function and cell signaling has come up, and we have got that chromatin regulator in the form of histone modifying enzymes and chromatin remodeling complex, that is sucrose, switch sucrose non-fermenter, that is MRC B1, MRC A2, MRC A4, and also not rearranged malignant tumors. I think you are quite you are just knowing these terminologies. So what are the usual presentation of these tumors? They are mostly undifferentiated. You cannot have idea about their histology from their histologic appearance. Suppose a sarcoma showing INI or SMARCB1 loss, epithelioid sarcoma. So by its name, it is quite obvious that there are some confusion, that cells are looking like epithelium, but the tumor is sarcoma. Similarly, In lung also we are getting SMARCA deficient undifferentiated carcinoma, SMARCA4 deficient undifferentiated neoplasm. In sarcoma cases also we are getting that SMARCB1 deficient. So there are this family is expanding, particularly with the use of these next generation antibodies. I mean use of these next generation antibodies which are IC based tests, and monoclonal antibody against that not rearranged sarcomas are also available. There are so many partners for that BRD4, BRD3, NSD3. These are all these fusion and also even BCOR and CIC are also are partner now becoming now revealed to be the fusion partner of these not rearranged tumors. That conventionally we knew that CIC, DUK rearranged sarcomas. We knew that BCOR rearranged sarcomas, but now it is seen that BCOR is supposed to be one fusion partner of NAT also. So gradually there is expansion of this family of tumors where you cannot lump those cases into conventional classification system as epithelial or mesenchymal. So there lies the utility of these next gen antibodies which are IC based tests and also the next generation sequencing. So this has become slowly an important part of this diagnostic workup. Dr. Indranil has also focused about the importance of these tests, which I am coming later. The presence of core needle biopsy over FNA is related to the ability of the pathologist and radiologist to provide multiple cores at the same time, and the flexibility of the pathologist to triage the tissue adequately for ancillary studies including ISC histochemistry, molecular studies, and nowadays next gen sequencing, and also some ISC based tests which are associated tests like PDL1 ISC. That is called qualitative test for PDL1. And then comes the other advantages, like it provides good cellular details with preservation of architecture that you have got idea, and useful lesion in lesion with desmoplastic and sclerotic stroma. It is not only the use of the core needle biopsy. We have to put equal importance on the cell block also nowadays, and it should be complementary to each other. But there are some cases or there are some conditions where you really feel difficulty in case of procurement of proper FNA material and thereby preparation of the cell blocks. Like these tumors or lesions having desmoplastic or sclerotic stroma. It's very difficult to get material. Now, another important thing for this TrueCut or core needle biopsy, more tumor cells are available for different ancillary and molecular studies. You can get multiple cores, and another important thing, that simpler touch imprint technique has wider use and better acceptance. That from touch imprint you can go for rapid on-site evaluation of your material, whether your material is satisfactory or not. In this context, I should say that we had worked on this adequacy of touch imprint smear, where we put the adequacy criteria of Yokohama breast, that 7 cells, 10 clusters like that, and had conducted a study to assess the adequacy of touch of core from touch imprint smear, which plays an important role as in ROSE, that is rapid on-site evaluation. And that work has been accepted in JOC, supposed to be published very soon. Now, application of next-gen sequencing. So, a lot of discussion has already been made by Dr. Indranil. He had focused this important investigation in right time and also made my work bit lesser. Now, one important thing when you are thinking of next-gen sequencing, is it that always you are submitting your material for next-gen sequencing? Is it possible for us in this setup? No, it is not possible. So you can really think seriously about next-gen sequencing when your material is very less, particularly which you might be facing in case of biopsy from lung. From breast, you can go for another core, another more core, but from lung, it is really very difficult. So you can think of next-gen sequencing in lung, and also sometimes in soft tissue tumors. And another important thing for breast, also you can think of next-gen sequencing, because you know what we do in breast cancer, initial workup from TrueCut or core needle biopsy. I have already told that we diagnose the case as invasive carcinoma and other associated things which I have already told. I am not repeating, but you know that you have got some idea about the molecular classification, how much it is given stress nowadays, and so you will have to have an idea about the molecular classification, which is absolutely dependent on TCGA data. You know that hierarchical classification was made, and from there the pattern, the types, that is luminal A, luminal B, and then what is luminal A, luminal B, HER2 enriched and basal like. These are the four, and one is normal breast tissue like. So these are the pattern or types which described. That was absolutely based on TCGA data. Before that TCGA project was not done or completed, this was not available. So what happened then? It was dependent on the surrogate system of molecular classification, which was based on this ERPR HER2. And this was like luminal A like, luminal B like, not luminal A. So, and St. Gallen's, 13th St. Gallen's conference was also adopted this system in 2013. So, as because that this was dependent on TCGA data, and which subsequently needed to be refined and much more representative on the basis of the RT-PCR based tests, like that you can, if you go through your WHO book, you can get that PAM50 gene signature. So signature based studies. So after getting that ERPR HER2, then you will have to have a signature based studies like ProSigna, MammaPrint, PAM50 gene signature based tests. But these, that like PAM50 gene is a RT-PCR based test. It is also not that much easily available and also costly test. So it was not acceptable all over worldwide, it was not acceptable. Naturally, St. Gallen's 13th conference, international conference of at 2013 accepted or adopted that surrogate system, which was based on ERPR and HER2. But from there, you know that luminal A, there are some genetic abnormalities which you can suspect. Like luminal A cases can show PIK3CA mutation. Okay, and if particularly if you go for triple negative breast cancer, that is really a diagnostic challenge and also therapeutic challenge. So when you are going for that triple negative breast cancers, so how it was classified initially from TCGA data, it was as luminal A, luminal B like that, and also some cases are basal like, which on the basis of ISC were stamped as triple negative cases, triple negative breast cancers. Then there was an attempt to get further subgrouping of these molecular subtypes or molecular types by combining the transcriptomic and genomic data. On that basis, another classification was integrated grouping system derived in case of this which mainly includes luminal A and luminal B tumors. But similar attempts were made to subclassify the triple negative breast cancers, where we are getting that basal-like 1, basal-like 2 and luminal AR and mesenchymal. And here we see that this luminal AR positive or luminal AR subgroup of triple negative breast cancer are showing high tumor mutation burden or high TMB. Okay, you know that tumor mutation burden or TMB high is supposed to be found in case of melanoma, in case of lung carcinoma and in case of colonic carcinoma. And TMBH is called TMBH when you are getting more than 10 mutations per 1 MB read of DNA sequence DNA. That Dr. Indranil was also telling. So you are getting more than 10. So usually you are getting in lung carcinoma and also you are getting in melanoma like that. But in case of breast carcinoma, where you are getting that TMB is about 1.64 or 1.65 like that in case of luminal AR, and so they are having bit more tumor mutation burden. Not exactly that high as 10 from which you can stamp it as TMBH tumor, not that, but still they have got higher. And it is seen that they are showing that PIK3CA mutation, they are showing that CDH1 mutation and they are showing AKT1 mutation like that. So a single tumor showing multiple tumor mutation. So these are, there is the need for multiplexing. Obviously, next gen sequencing will serve that purpose. That's why initially a small gene panel were in use for next gen sequencing. But nowadays, the larger cancer panel, which is called comprehensive genomic profiling, that is CGH, for solid tumors are routinely being practiced since 2020-21. And it includes 300 to 600 gene. Okay, so you can get abnormality or you can sequence 300 to 600 genes in that panel, which is called comprehensive genomic profiling. That is CGP, comprehensive genomic profiling. That Dr. Indranil was also telling 300, more than 300. So it is 300 to 600 which is called comprehensive genomic profiling. And another important thing which you must be knowing, that if you are supposed to detect that tumor mutation burden, TMB, you will have to have your panel having more than 300 gene. If it is less than 300, you cannot detect that. So now I think you are clear where from this small material or small biopsy you really need the requirement of next gen sequencing. So in lung cancer, where your material is really less, in breast carcinoma, where initial surrogate classification or molecular classification says that there could be chances of luminal AR, which is supposed to be having more tumor burden. And also in lung carcinoma, usually you are supposed to get TMBH. So there obviously you need multiplexing, and in single set tests is definitely most apt is next gen sequencing. Nowadays, after comprehensive, now whole genome sequencing is also being used, although this is very costly, but still it has got some role, additional role in detecting particularly that BRCA1, BRCA2 mutation, and also you know that triple negative breast cancers are supposed to develop BRCA-ness. That means subsequently they develop BRCA mutation, and that can be also detected. And also that whole genome sequencing detects the not only the mutation present, but also it reflects or gives some idea about the tumor cell biology, that is UV radiation induced damage, homologous recombination, repair defect, that is HDR, and also detection of other simultaneously other mutations. But still now whole genome sequencing is not of that use because it is more expensive and it is not possible from small quantity of tissue in core needle biopsy. And another important thing is that lot of informations generated are difficult to be interpreted due to uncertain clinical significance. So lot of experience is also required for complete that is whole genome sequencing. So now coming to that qualitative ISC, which is also required as initial workup in your small material, that I have already told, that PDL1 ISC, which are recommended by US FDA, approved by US FDA, and there are the clone used in different systems are differently approved. Like some clones are approved for Ventana platform, some clones are approved for this DACO platform, and you will have to mention, or you will have to receive that information in your report, so that appropriate anti-immune therapy, that is the PDL1 inhibitor, will be different according to the clone used and the system used. So that's about the tests which are supposed to be having in your initial workup after getting a proper histological diagnosis and grading of your tumors. But though these are nowadays very much becoming important, but still histological diagnosis is very much important, because it will direct, or it will give you an idea about the hunch for your molecular defects which you are supposed to get from that. So we should never ignore the importance of histopathology. Although a lot of words has already been discussed on the which really focused on molecular or other ancillary investigations, still I should say that histology is very much important. Don't ignore that thing. Now here I am just discussing a few of my cases which is mostly prepared for breast, true cut on breast. Just quickly going through this. A 22-year-old girl presented with complaints of swelling in the left breast for last 3 months. On clinical examination, the mass was firm, mobile and well circumscribed. So this was the scanner view of cytology or imprint, where you see that cohesive clusters with numerous bare bipolar nuclei are there in the background. And this is higher power. And this is the core. So what is your diagnosis? Which it is? Anybody? Yes, this is fibroadenoma showing benign epithelial component, mostly showing pericanalicular type of pattern. Some are showing intracanalicular, but mostly they are pericanalicular. So with no atypia. Diagnosis. Now case 2. 35-year-old female presented with large swelling in the left breast for last 6 months. On clinical examination, a firm, well circumscribed mass measuring 6 into 4 centimeter was found to be palpable in the lower lateral quadrant of left breast. Ultrasound showed a large heterogeneous mass lesion measuring 6 centimeter into 3.5 centimeter, having both solid and cystic components and mild internal vascularity. Can you give any idea? Is it looking like fibroadenoma, which we are supposed to get from cytologist smears? These are the epithelial clusters. Another part of the smears. From this, fibro? Yes. So these cells are a bit different from bare bipolar nuclei which you are supposed to get. The spindle separate cells are there. I think you can get this from core needle biopsy. We are seeing predominance of the stroma, and the stroma is different. I think you can also appreciate the periepithelial accentuation of the cell, which will be much more prominent in higher magnification. So these are the cellular stroma. Other areas, the epithelial component is less. The other areas showing stromal hypercellularity. In the center you can see some epithelial like this part. So diagnosis was benign Phyllodes tumor. Case 3. Presented with 58 years, progressively increasing lump in her right breast for last 1 year. On clinical examination, the mass was hard, tender, well circumscribed, measuring 6 centimeter into 5 centimeter and located in the upper lateral quadrant of the right breast. So you see cellular, you can see the cellularity of the smears. Another higher magnification. Can you describe any of the PGT? Describe this smear that shown in higher magnification. So this part you see, this is another important thing which you can search. Actually, in our paper also I focus this part and given stress on this part. So when you are getting this type of cellular smear, the cells are not that much pleomorphic in appearance. If you are getting this type of tubules, you should be very much cautious. Probably this could be a low grade malignant tumor. You should search for this, and if you find this type of tubules, you should be alert of this finding. Now see the core. From this core, what you can say? I think you will be able to answer. Please be louder. Yes, that there are multiple DCIS focus, but apart from that you are also getting an infiltrative component, and that was the problem. From smears, maximum what we could say that this is a atypical proliferative breast disease, and from this true cut biopsy at least we can make that this is invasive carcinoma with an intraductal component, and that is also required. That is the requirement as a in your report, that if there is intraductal component you should mention. This is a higher magnification. So infiltrating ductal carcinoma of no special type, Now it is called invasive breast carcinoma, bracketed ductal. In the bracket they are putting ductal. 65 years, female presented with complaints of progressively enlarging lump in the left breast for last 3 years. On a clinical examination, the mass was hard, irregular, measuring approximately 8 into 7 centimeter with overlying skin ulceration and involvement of nipple located in the lateral half of the left breast. What you can say from this smear? So this much you can say that there is high cellularity and the cells are predominantly in clusters. This is a higher magnification. You can see some cells are showing nuclear enlargement, and also these cells, these clusters is not that much cohesive, rather discohesive. An isonucleus is there, and also the cells are showing hyperchromatic nuclei. This is the core. I think now you can say what it is. What could be the diagnosis? PGTs. Invasive lobular, yes, but really it is a difficult issue from cytology smears. We cannot be very much confident on our diagnosis of lobular carcinoma. We may suspect that this could be lobular, still we write in the bottom line that atypical proliferative breast disease. So that's how we are a bit ahead in this core needle biopsy. At least we can offer the diagnosis of invasive lobular carcinoma, and you see in higher power the cells are definitely looking malignant, hyperchromatic. So pleomorphism is there and breast mitotic activity was also observed. So infiltrating ductal it was a ductal carcinoma, right? Next case is lobular. These cells are bit hyperchromatic pleomorphic. So in the scanner power it was looking like lobular carcinoma, but in higher power we revealed that these cells are pleomorphic and we diagnosed it as invasive ductal carcinoma, no special type. Now case 5, tender lump measuring 9 into 7 centimeter in her right breast. Breast examination revealed a similar mass in the left breast measuring 5 into 4 centimeter. The right breast lump was extensively involved the skin in front, ulceration and erosion of nipple areolar complex. So this was the cytology finding. What you can see few clusters, small clusters, and the smears are relatively paucicellular. Okay, this is another important point, that the cells, the smears are paucicellular, showing small clusters, and some single cells are also there in the background. From there, it is really very difficult to give any opinion in favor of malignancy or even a neoplastic pathology. And these are the higher magnification. You see that clusters, but the cells are bit loosely cohesive and single cells are also there in the background. And this was the core. Can you follow the Indian file pattern there? Now what you can see, this is what it is. This is lobular carcinoma in situ component, okay, and also there are some invasive components are there. Now in higher magnification, you can appreciate the Indian file patterns. So, this is okay, done. So, up to this, now we know how to get our material. What are the indications? Dr. Pathak has covered the contraindications, the precautions which are needed to be taken, and also the complications like hemorrhage, pneumothorax. So, how you will manage? So, I have not included all these things in my presentation. I think those are very much complete, which Dr. Pathak has included, and you should follow, and you should have a study on those things, and what are the basic investigations which are to be needed before you go for core needle biopsy, and how you approach that radiological part and clinical part was very nicely covered by Dr. Pathak. Now, I am going to video. So, now I am going to a video presentation of the procedure and procurement of the material. As sir has covered that what are the different parts of the needle, he had told what is trough, what is bevel. So, I am not going to the details of those in my presentation, rather we can discuss it in our hands-on training part, and there you can also ask me, or I can show you that parts on that instrument. Now, you see this video how a basic of the part which is usually followed. See, these are the instrument. This is the gun, which is called spring loaded gun. So, all these things are required, and you know that local anesthesia part, after proper dressing and draping, we are going for introducing local anesthesia. It is usually that xylocaine which are used in our OT. So, that I am trying to give you an idea about the lump. Is it showing? Yes. So light थोड़ा कम हो रहा है क्या? हाँ কি করবে ওটা কমাতে হবে? না না আপনাকে কিছু করতে হবে ব্রাইটনেস ওকে এখানে তো ফোকাসটা হচ্ছে এখানে গিয়ে হ্যাঁ এবার ঠিক আছে নাও ইট ইজ ওকে সো this is the local anesthesia part, particularly that skin overlying the tumor mass. Usually I try to do maximum coverage by single introduction. So, that is why I direct my needle in different direction from the same entry point. So, after waiting few minutes, then again spirit, clean it by spirit, then followed by betadine and again spirit, the usual steps which are being followed. So, I think you can have an idea about the size of the mass. Now, this gun is taken out. So, that is how you can release those parts. Now, it is ready for use. I'll show this in the hands-on part, the different parts and how to make it ready. So you can just, I am trying to show this, that switch part is there, and you introduce. Some prefer cutting it by nick, but I don't use that. So after introducing, just firing is done and the material is collected. You can see the material is there in the trap part. So that Dr. Pathak was showing the trap part, that means the depressed part where the material is there. So you can get the material by using this needle. Another important procedure is just touch it on your gloves and roll it, then the material will be there. I will show there in the hands-on part. Now you can see how the core of which length, it is quite satisfactory core. Then the imprint smear is taken by dragging it and rolling it on the slide. That imprint smear is now being prepared, and that the core is placed into the formalin fixative. So as early as possible you can place it in the fixative. That's the advantage. So you can tackle, or you can take proper care of the fixation of the cores. Now that slide is put in alcohol for alcohol fixation and subsequent staining. After initial operation, usually we wash it in normal saline, then by betadine gauze, and then again we take one dry gauze, then again this is ready for use. Now you see how I am getting it ready. Then going for the second fire or trajectory. Can you follow? So that part is necrotic. That's why the core become fragmented. course, na? There are 4 courses. I think there are 4 courses. Usually I keep the cover of the paper which is used for gloves, na? So I keep it on the table. So that is supposed to be sterile kind of. So now the process is over and we are giving proper bandage by gauze piece and micropore, all that. So that's all about quick description, I mean steps, display of the steps. I think you can follow this and we shall do these steps on Asitabu, Dr. Asitabu, on which we are going to do this on in hands-on. They have taken. Okay. So now we shall do this on chicken breast, right? So thank you for your patient hearing. And remember one thing, that it is not only the thing that you are getting it done. The main important thing is you should give proper respect to that tissue material which you have collected. Particularly in this era of personalized medicine or precision medicine, you will have to do proper justice to that tissue which you have procured by this cord biopsy process, and you will have to do best possible, that is doing more with less. That means you will have to try to cover almost all diagnostic workup by this less amount of material, that is the small diagnostic sample. Okay. Thank you.
Thank you very much, sir. We are grateful that you shared your expertise and engaged our audience. Now, I request Dr. Babai Halder, sir, to felicitate our speaker. Next, I would like to invite Dr. Soma Malik from TOS India to speak on the topic molecular allergology, component resolved diagnostic in the field of allergy.
Good afternoon, everybody. Though it's a fag end of the day, all tired. Very good afternoon. I'm here to talk on allergy profiling. Throughout the day, we had lot of words which will go common today, like molecular, artificial intelligence, precision medicine. So we will see and we'll club it here in the domain of allergology. Allergy profiling with respect to component resolved diagnostics. If you see the conventional form of allergy, it talks about, if you see the pyramid, traditional or conventional methods are skin prick test. On the volar region of the hand, we do skin prick test, and as far as in vivo diagnostics is concerned, and in vitro we do extract based testing. That is, to some extent, crude extracts are used for the same, aqueous extracts, and followed by molecular testing or molecular diagnostics in the field of allergy. Now try to understand what it is when we do an extract based testing, be it SPT, be it in vitro. Usually we use the allergen sources. There are three pictures. You can see there is a picture of a peanut, an apple, and a dust mite. Whenever we see a report, we see the names of the allergen sources on it. Like a patient is positive to dust mite, a patient is positive to an apple, or a patient is positive to, say, a peanut. What we do here is, if you go through the technological, throughout the flow of generation, it is usually a homogenizer is used where you homogenize a source and then we separate the proteins and then we put it on a solid phase and we do the testing. But it is true to understand that in a source there are varied kind of proteins which are both allergenic and non-allergenic. Now how do we differentiate those while doing a test is our concern. So from if you go through the generation 1 where we talk about the entire source as used for testing, followed by the crude homogenized or the whole extract, followed by the purified proteins, then it is followed by the characterized purified extracts, and then we talk about recombinant DNA technology. Now, how does it all affect? It affects the specificity scale of testing. The false positives, we have to reduce the false positives on our allergy report. So, from whole extract to a molecular allergen, the scale differs to a manifold form. Now, a pictogram which depicts on an extract level the allergens being used. If you see there are carbohydrate cross-reactive determinants, there are underrepresented allergens, there are protein cross-reactivity, there are masked allergens, but these creates a false positive report. On the other hand, the molecular, all these are taken care of. There is no CCD interference, there are no masked allergens, and we get a recombinant allergen. So, I can tell no more an allergen source to be considered as allergens. It is the molecular or the proteins which increases the allergenicity are the allergens. So, we cannot tell an apple to be an allergen. We can tell something called MALD1 to be an allergen. So, MALD1 is a protein present in apple which is causing allergenicity. Some examples to make it a little more clear. Dust mites. For dust mite, it is not a dust mite allergy. A patient comes with rhinitis, rhinoconjunctivitis, redness of eyes, angioedema, and you go for a test and you find that the patient is positive for dust mites. So there's nothing called a dust mite allergy. It is a DERPI 1 or DERPI 2 or DERPI 10 or 23. So dermatophagoides pterodicynus, or it can be dermatophagoides farini. For an apple, it can be MALDI 1, MALDI 2, MALDI 3, MALDI 4. For peanut, RAH1, RAH2, RAH8. Milk for BOSD 4, 5 and 8. Likewise for other allergens too. Now, after we have done the molecular component analysis, they are put into a protein family. Each protein family behaves in its own way. Some protein families are heat stable, digestive enzyme stable. Some protein families are not. So these proteins which causes, they fall into some protein families like LTP, storage proteins, tropomyosins. Like here, storage proteins and tropomyosins are the most heat stable and digestive enzyme stable proteins. So all the allergens which fall in these families, the patient has to avoid that totally. Now, why are we so specific in allergy? If we are so specific in HIV testing, if we are so specific in dengue test, so in hepatitis and COVID, like we use a capture protein for all these kind of tests, why not for allergy? So in allergy too, we have to have a capture source for allergy. It is no more allergen source cannot be considered as a diagnostic test for allergy. Another very interesting case study, many a times, there was a patient in Rajasthan who was a pure vegetarian patient, and he got a positive for shrimp, and the patient was very upset and was telling entire family, we have never touched shrimp, so how can I be positive for shrimp? But the funniest part is that this shrimp belongs to this penem 1, also belongs to a family of tropomyosin, whereas there is Blagi 7 from cockroach and DERPI 10 from dust mite. So this patient was either positive for cockroach or for dust mite, and as because penem 1 also belongs to tropomyosin, so this patient came positive. So whether this is a cross-reactive sensitization, not a genuine sensitization. So this is another thing, component resolved diagnostics or molecular allergy can help you to understand that whether it is a genuine sensitization or a cross-reactive sensitization. If the patient is positive for penem 1, that means it is a cross-reactive sensitization for that patient. Another very interesting as far as like dust mite diagnostic algorithm. If a patient is positive for DERPI 1 and DERPI 2, he is a right candidate for AIT or allergy immunotherapy. But a patient, if you see the entire scale, if it is like cross-reactivity, just now I shared with you the example. Somebody who is having DERPI 10 positive or 20, it has also cross-reactive with shellfish. That means that patient cannot undergo immunotherapy. So if a patient undergoes immunotherapy for a period of 6 months, there will be no improvement in the patient. So this is very important to understand in dust mite allergy, whether it is DERPI 1 or DERPI 2 or it is DERF 1 or DERF 2. If it is other than DERPI 1 and DERPI 2, they are markers which cannot guide immunotherapy. Even another very interesting, there are many pet lovers. I know there are some here, might not be here, but there are many pet lovers who come to the doctors and complain that I have my pet and they have allergy to it. Now it is very interesting, you can have that if a patient has got FeLD1 or FeLD2 or a CANF1, whether he or she can have a dog or not. Very interesting to share here is that a patient with a CANF5 positive, now CANF5 positive is always there in male dog urine. Now patient who has a dog, if he or she who has a CANF5 positive can have a female dog, luckily to have a pet but not a male dog. So pet lovers can avoid a male dog and can have a female dog instead. So this is another very interesting thing, and another thing is that many a times it has got cross reactivity with horse, that is EQC1. So many polo players, it has been found that they are positive to horse too. Some markers, some allergy markers like FeLD1 for asthma, untreated FeLD1 positive patients can develop asthma. Aspergillus fumigatus 4 and 6 for ABPA, and another very interesting thing, I don't know whether doctors have this kind of patient, food dependent exercise induced anaphylaxis, where people taking food and going for an exercise or a dance class or something, there can be an anaphylactic shock in that patient. So it is very important to do a molecular diagnosis, especially for wheat allergy. This is an extract based, like why and how it is. I started my talk by talking about extracts, crude extracts and molecular. This is a picture of our protein electrophoretic slide, which talks about how different and how extract proteins and a molecular protein, how the bands look like. The M band is the molecular and the others are the extract ones. You can understand how fusing are the bands. So if you have this kind of bands and you take these kind and put it in your extracts, so there is a high chance of getting a different kind of a report. Very important to share here is the CCD, cross-reactive carbohydrate determinant. If you see, there are many times there are plant allergens like the lentils, the pollens, the grass pollens, the nuts. They come to be highly positive. They are because cross-reactive carbohydrate determinant is one of the very important component which is very much prevalent in plant allergens, and specifically lentils, pollens. So if you cannot or do not nullify these CCDs, you will get a report with lot of false positives. So to get a true report, you have to nullify CCD, and that can only be done in molecular form and no other way. So this is how it is done, the process, and this is a multiplex slide. You can see this is a multiplex slide where in this is a cartridge where 295 allergen tests can be done in one platform. So in these two cases, you will see how many colored dots are there, and they are all false positives. And on the other hand, you see after the CCD inhibitor has been used, see the number of dots. So many a times the patient and the clinician both get confused how so many of positives, what to tell to the patient and how to clinically treat the patient. As I was sharing with you the protein families, I had named few, and I had shared with you that protein stable to heat and digestion. Higher chance of severe reactions, the ones which belongs to storage proteins, or that belongs to tropomyosins, or it belongs to PR10, they are highly, you have to avoid it completely. Those allergenic patients has to avoid anything of that kind completely. So proteins that are not stable to heat and digestion, are labile to, they can be, the systemic reaction will be much lesser in those kind of patients than those patients who has allergens which belong to the stable protein families. I would like to guide you with some examples. Peanut. Now, a patient with where there is RAH8 positive, they can have a peanut muffin or a peanut butter on their toast or something. But a patient with RAH1, 2 and 3 positive might develop anaphylactic shock, and it can be as severe as death. So this is very particular, that whether you are doing an RAH1, 2 or 3 or getting RAH positive. That is very important. So the families, no reaction, the CCDs which I told has to be nullified. The mild reaction proteins are PR10, polcalcins and serum albumins, and the severe reactions are storage proteins, LTP, tropomyosins and parvalbumins. This is one case study, this is one slide I want to share with pediatricians I do with a CMPA allergy. Children after BM stops, the weaning starts and cow's milk is introduced to the child. There are many a times we find that that patient is positive for 2 CMPA and it's called a CMPA allergy. In that case, if BOSD8 comes positive, which is the major allergen as far as milk is concerned, that child has to avoid milk completely. But instead, if the child has got BOSD4 and 5, milk derivatives, baked form of milk can be given to the patient in the form of yogurt, casein or anything. But if it is BOSD8 complete, you cannot give the child milk at all. So this is a very important thing, and that really has made many of the pediatricians, when they talk to me, they find it very interesting and they share that yes, truly molecular allergology is really helping in understanding a true CMPA allergy is there or not for a child. Some more examples like egg. Egg is another thing which is introduced to children. So children with GALD1, ovomucoid positive, you have to avoid milk in any form. But with patients with GALD3, 4, if they take anything, a cake where egg was there or a muffin where egg was there, the severity of reaction will not be that much. Even for milk, I have just discussed, the peanut I have discussed, and apple also I have discussed with you. MALD1 is one of the most, if it is in PR10, but MALD3 is LTP, and MALD3 has to be avoided completely. This is the system, Alex2 is the system. There is one, we have our, the showcasing of the systems outside in the big hall. So you can see Alex2, it's a very interesting, a cartridge is there where 295 allergens are posted in one file. This is a very scientific, 295 allergens in one small cartridge, and you can screen 295 allergens at one go. A case study, a 30-year-old male comes in complaining about constant blocked ears, stuffy nose and breathing difficulties. He noticed the symptoms get worse at home and sometimes on consumption of certain types of food. An extract-based testing was done on the patient and he was found to be positive. The same patient had also been given dust mite molecular, where it was found that DERP1 7 and DERP2 was 13 and DERP10 was 0. So this is a case study where this patient is actually a AIT. This patient can get improved if AIT can be processed on that patient. But if it is found that DERP1 and DERP2 is 0 and the DERP10 is 12, that means AIT cannot be given or it will not have any effect on the patient. Another one, a 12-year-old boy is brought to and induced to complaints regarding development of urticaria all over the child's body on the consumption of peanuts along with the development of gastrointestinal issues. Now extract only gave 15 and you understand if there is a peanut allergy. But when a molecular was done, it was found that RAH1 was 10, RAH2 was 4 and the RAH8 was 0. So avoidance is the solution, and peanut in roasted form cannot be given. If the patient would have been positive, had shown a high titer at RAH8, then roasted peanut or peanut butter or anything of that kind, derivatives from peanut could be introduced to the patient. With this, I end the allergy slides, but there's another two important things I would like to share. That is Percepsin, a specific biomarker for bacterial sepsis. Here there is a machine called AI360. These two can be introduced. Percepsin, a specific biomarker for bacterial sepsis. Now, sepsis is defined as the life-threatening organ dysfunction caused by a dysregulation host response to infection. Now, I would like to here talk about our Percepsin, which is a neonatal the best guidance for early onset of neonatal sepsis or late onset of a neonatal sepsis. And it has been found, we have papers, we have lot of guidelines which talks how Percepsin gives you a clear picture of a early onset of neonatal sepsis and late onset of neonatal sepsis. I would like to tell you here that there are a lot of, though blood culture continues to be the gold standard for diagnosing sepsis, but you understand what are its limitations. The results are obtained over several days. They have a low yield in patients who are receiving antibiotics, have been or previously treated with antibiotics. This delay may contribute to further worsening of critically ill sepsis patients, thereby increasing morbidity. So none of the other tests have been proven to be accurate enough to distinguish sepsis from SARS. So we are talking here about Percepsin, early diagnostic marker. Very important, in response to bacterial infection, its concentration increases within 2 hours of onset of sepsis. This is the one slide I want to tell, I always share, and it is true that really, if we have a marker which concentration increases within 2 hours of onset of sepsis, it would be really beneficial for the clinicians as well as the laboratory. Allow the clinicians to confirm an infection suspicion in an early phase of the disease. This is the case study. This is a case study on early onset of sepsis. And Percepsin is an early diagnostic marker for early onset of neonatal sepsis. This is also late onset of neonatal sepsis. Percepsin was higher in the late onset than in the control group at enrollment. Throughout the evaluation period, the area under the curve was 0.972. And very interesting case study. Procalcitonin is one of the popular things being used, but its half-life is 12 to 24 hours, delay in management of the pharmacological treatment. Procalcitonin, I know, is being used everywhere. So, but Percepsin has a half-life of 4 to 5 hours, allowing more effective and earlier management of the pharmacological treatment. This can be done in a system called AI360. Already the lab here has this. Since 2016, the machine is there. Many parameters are being done here. They can introduce Percepsin along with others. So fast result, mortality increases 7.6 for every 1 hour. So the Tosho AIA gives a report in 20 minutes. I think it will make a difference. Measuring range, sensitivity 2.9 picogram per ml, linearity 20,000, hook effect is more than 50,000 picogram per ml. Now I would like to talk about another marker, KL6 for ILD, interstitial lung disease. Interstitial lung disease are associated with significant morbidity, mortality and increased financial burden. The overall prevalence of ILD was 20% higher. Whenever I talk about allergy to pulmonologists, or when we talk about, so KL6 is another thing and they find it interesting. So I felt that why not talk to you about the same. So the overall prevalence of ILD was 20% higher in males than females, increased prevalence due to COVID-19. The most interesting thing, the prevalence, if you see, India has a multi-site mix for idiopathic pulmonary fibrosis, for connective tissue disease, hypersensitivity, pneumonitis. It has a lot of, when talking to the top pulmonologists, I have shown this slide, and I always, when I am there with the clinicians and the lab, I always try to justify the slides I show. So yes, it's true that India has a multi-site for ILDs. It can be an interesting, pool of patients for ILD. So interstitial lung disease, 200 plus subtypes, also called diffuse parenchymal lung diseases. So why KL6? I am making it short for all of you. Why KL6? Specific lung biomarker, detecting the disease presence, evaluating the disease activity, predicting outcomes. It is accurate, rapid, reproducible, and non-invasive, and easy to perform. It can be also be performed in AIA 360. So if the system is there, they have to introduce the parameter only. KL6 correlation with COVID. KL6 is more and more showing to become and more important variable in the assessment of COVID-19, as it reflects the status of the patient's lung functionality in an early stage. Multiple studies supports KL6 as a biomarker of COVID-19 severity and also a predictor of the prognosis of lung injury of discharged patients. So first time on immunoassay AIA platform, KL6. This is the capture antibody. This is the detection, 100 microliter of anti-KL6 mouse monoclonal antibody conjugated to bovine alkaline phosphatase. Calibration stability, the very important, because KL6 will be not a very frequent test for the lab. So the calibration stability I would like to highlight for the labs. It is 90 days. So 90 days, no calibration required. Measurements range, sensitivity, diluted sample 0.278, linearity 117 U per ml, original sample 6000 U per ml. Thank you. Thank you for listening to me at the fag end of the day. Thank you.
Thank you so much, ma'am, for such an informative session. Now I request Dr. Ashok Prasad sir to come up the stage and felicitate our speaker. Now I request those who registered for workshop to proceed for hands-on training, which will be held in practical room of Department of Pathology. But after that, we have much awaited cultural program, which will be started at 7 o'clock, followed by dinner. Thank you very much for your patience.